Welcome to the Deep Dive. Today we're tackling a really critical topic, high alert medications, central nervous system depressants, and muscle relaxants.
Yeah, these are the drugs that, calm people down, help them sleep. Powerful stuff.
Exactly. Which means understanding the pharmacology, the safety. It's absolutely non-negotiable for anyone in healthcare, especially nursing students.
That's our goal today. We want to give you a solid, efficient shortcut through the main classes. Think benzodiazepines, nonbenzodiazepines, barbiturates, the newer orexin antagonists, and muscle relaxants, too.
And the focus is really on safety and how you actually use this knowledge in clinical practice, making sure we understand the difference between just knocking someone out and promoting, well, actual functional rest.
Right. And to do that, we have to start with the basics, the language of sedation. It all comes down to dose, really.
So it's dependency, okay.
Yeah. So if a drug mostly just reduces nervousness, excitability, maybe irritability, but doesn't necessarily cause sleep, that's a sedative.
Okay, it just takes the edge off.
Pretty much. But if you increase that dose and it does cause sleep, now it's acting as a hypnotic, more potent CNS effect there.
Got it. So most of these drugs we're discussing today fall into that combined category then, sedative hypnotics.
Exactly. They can be either, depending on how much you give and, how the patient responds.
And what's the main target in the brain? What are these drugs actually doing?
They're mostly interacting with GABA, gamma-aminobutyric acid.
The main inhibitory neurotransmitter.
That's the one. Think of it as the brain's brake pedal. Most of these drugs work by making GABA more effective, pressing that brake harder.
Okay, so more GABA action equals more CNS depression. Makes sense.
Which leads us straight into thinking about sleep itself. Sleep architecture.
Right, it's not just an on-off switch. You've got the cycles, non-REM stages, and then REM sleep, the dreaming stage. Why is that so critical when we talk about these drugs?
Because a lot of hypnotics really mess with that architecture. They can cause REM interference.
Meaning they reduce the amount of REM sleep you get.
Precisely. So someone might look like they slept for 8 hours, but they didn't get enough of that crucial REM stage. They wake up feeling tired, functionally fatigued, like that patient case, P.S. sleeping, but still exhausted.
That connects the dots. And what happens if they stop the drug suddenly?
Then you risk REM rebound. The body tries to catch up, leading to this surge of REM sleep, often with really intense, vivid, sometimes disturbing nightmares.
Oof. Okay. Definitely something to warn patients about.
Absolutely. Understanding that cycle is key for patient education.
All right, let's dive into the first major class. Benzodiazepines. Still incredibly common, though. Definitely under more scrutiny lately.
They are. They work by boosting GABA's effects. They bind to specific spots near the GABA receptors in the brain. Think hypothalamic, thalamic, limbic systems.
Which makes them useful for a lot of things.
Oh, yeah. Sedation, anxiety relief, they're great anxiolytics. Also for managing acute seizures, even relaxing skeletal muscles. Very versatile.
And the easy way to remember them is often that PAM or LAM ending, right?
Yeah.
Diazepam, temazepam, midazolam.
That's the classic clinical pearl, yeah. But the duration of action is really what you need to nail down for safety. You've got long-acting, intermediate...
Like temazepam. I know that one's often given about an hour before bed.
Exactly, intermediate. And then the short-acting ones, like midazolam, we use that a lot for moderate sedation because it causes significant amnesia along with the anti-anxiety effect.
Okay, duration is key. But let's talk warnings. The black box warnings are serious.
They really are. The whole class carries them now. The 2020 update covers the significant risk for abuse, misuse, addiction, physical dependence, and some really nasty withdrawal symptoms. It's a big deal.
And that's on top of the 2016 warning about combining them with opioids.
Which is just a terrifying combination. The risk of extreme sleepiness, severe respiratory depression, coma, even death is incredibly high. If you absolutely have to use them together, the monitoring has to be intense, constant vigilance.
Beyond those huge warnings, what are the more common side effects?
Well, you'll see headache, drowsiness, dizziness, but you also need to watch for paradoxical excitement or nervousness.
Wait, paradoxical. So the opposite effect, it makes them agitated instead of calm.
Exactly. It's an idiosyncratic reaction, more common in kids and older adults. Instead of calming down, they get restless, agitated, even aggressive sometimes. It's startling if you're not expecting it.
Wow, okay. And the fall risk?
Huge, huge fall hazard, especially in the elderly. Dizziness, sedation. It's a recipe for falls.
We also have to mention interactions.
Yeah.
Alcohol, other depressants.
Additive effects, definitely. Alcohol, opioids, muscle relaxants, combining them increases the CNS depression. But the specific food interaction to know is grapefruit juice.
Ah, yes. Grapefruit juice. Why is that one so important?
It messes with the liver enzymes, the cytochrome P450 system that break down the benzo. So the drug hangs around longer, levels get higher, and you risk toxicity.
Okay, so avoid grapefruit juice.
Mm.
If toxicity does happen, what's the move? Is there an antidote?
Yes, thankfully. For benzodiazepines, the specific reversal agent is flumazenol.
Flumazenol. How does it work?
It competes directly with the benzo for those receptor sites, knocks the benzo off, reverses the sedation.
But there's a catch with flumazenol, isn't there?
Yeah.
Something about its duration.
Right. Flumazenol has a very short half-life, maybe 1 to 4 hours. If you used it to reverse a long-acting benzodiazepine like diazepam, the flumazenol can wear off while the benzo is still active.
Meaning the sedation comes back.
Exactly. So you might need repeated doses of flumazenol. You have to keep monitoring closely.
That is a critical clinical point.
Hmm.
Okay, let's move away from the benzos. What about the non-benzodiazepines, the so-called Z drugs, like zolpidem?
Right. Zolpidem, Ambien, isoprene lunesta, Zaloplan Sonata. Chemically, they're different from benzos, but they work in a pretty similar way, targeting that GABA receptor complex.
They're supposed to be safer, right?
That was the hope, but they have their own serious issues. There's a 2019 black box warning for the whole class about complex sleep behaviors.
Things like sleepwalking, sleep driving, doing things while technically asleep.
Yeah, and sometimes dangerous things with no memory of it afterward. It's a major safety concern.
Zolpidem, Ambien, is probably the most well-known. It's short-acting, which helps with daytime drowsiness.
Generally, yes. But even with Zolpidem, especially the controlled release version, Ambien CR, which is designed to help people stay asleep, there's a documented risk of somnambulation, sleepwalking.
And there's specific dosing advice for women with zolpidem, isn't there?
Yes, the FDA recommends lower doses for women, typically 5 milligram max for the immediate release form. Studies showed women metabolize it more slowly, leading to higher levels the next morning, and increased risk of impairment, like while driving.
Good to know. Now, let's talk about a totally different mechanism, the orexin receptor antagonists,
Yeah.
like suvorexant, dulsamra.
This is a fascinating one. It doesn't directly depress the CNS like the others. Orexins are brain chemicals, neuropeptides, that basically tell your brain to stay awake.
Okay, they promote wakefulness.
Exactly. So suvorexant is a DORARA, a dual orexin receptor antagonist. It blocks those stay-awake signals, which allows sleep to occur more naturally. It's turning down the wake-up call, not just hitting the brakes harder.
Interesting approach. What about its kinetics? Does it last long?
It does. It has a pretty long half-life, around 12 hours, which of course means you have to be concerned about daytime sleepiness carrying over.
And I remember reading there's a gender difference noted here, too.
Yes, adverse effects like drowsiness and dizziness seem to occur more commonly in females with suvorexant. Another point for careful assessment.
Before we leave this newer group, any others to quickly mention?
We should touch on Rameltian, Roserum. It's structurally similar to melatonin and works on melatonin receptors.
And the key thing about Rameltia.
It is not a CNS depressant, and it's not a controlled substance. Its main use is for people who have trouble falling asleep, difficulty with sleep onset. And one specific instruction, avoid taking it with or right after a high-fat meal, as that can interfere with absorption.
Okay, good distinction. Now let's rewind a bit historically. Barbiturates. They used to be the go-to, but not so much anymore for sleep. Why the change?
Safety. Plain and simple. Barbiturates have a very, very low therapeutic index.
Meaning the gap between a helpful dose and a dangerous dose is tiny.
Dangerously small, yes. It's easy to slip from therapeutic to toxic. Plus, they are highly physiologically habit-forming, leading to dependence.
How do they work, mechanistically?
They're potent CNS depressants acting on the brainstem, particularly the reticular formation. They also enhance GABA, but maybe in a less specific way than benzos.
So are they used at all now?
For very specific things. Ultra-short-acting ones are still used for anesthesia induction. Long-acting ones, like phenobarbital, are used for seizure prevention, epileptic seizure prophylaxis. But for just inducing sleep, not really recommended anymore.
And they have a notorious interaction profile, don't they? Something about enzymes.
Yes. They are powerful enzyme inducers.
Okay, break that down. What does enzyme inducer mean in practice?
It means they rev up the liver's enzyme system, specifically the cytochrome P450 enzymes. These are the enzymes responsible for breaking down many, many drugs.
So the barbiturate makes the liver break down other drugs faster.
Exactly. It accelerates the metabolism of other drugs taken concurrently, which means those other drugs don't last as long or work as well.
That sounds like a huge clinical problem. The textbook example is always oral contraceptives.
That's the classic one. If a patient is on birth control pills and starts taking a barbiturate, the barbiturate can speed up the breakdown of the contraceptive hormones so much that the pill becomes ineffective.
Leading to unintended pregnancy.
Yeah.
Wow. So backup contraception is essential.
Absolutely mandatory. And besides interactions, barbiturates also mess with sleep architecture, heavily suppressing REM sleep. When stopped, you get that severe REM rebound, agitation, nightmares.
An overdose. Is there an antidote like flumazenil?
No specific antidote for barbiturates, unfortunately. Overdose causes profound CNS and respiratory depression. Treatment is primarily supportive, maintain the airway, support breathing and circulation.
But I remember something specific for phenobarbital overdose. Something about urine.
Right. For long-acting barbiturates like phenobarbital or methobarbital, sometimes a strategy is to alkalinize the urine, make it less acidic, often combined with forced diuresis.
How does making the urine alkaline help?
It helps keep the drug in its ionized form in the renal tubules, which prevents it from being reabsorbed back into the bloodstream and promotes its excretion out of the body. It speeds up elimination.
Okay, a specialized approach for a specific type. Let's switch gears now to muscle relaxants. What's their primary role?
They're mainly used for conditions involving muscle spasms and pain, like acute low back strain, that kind of thing, or for managing spasticity in chronic conditions like multiple sclerosis. They work best when combined with physical therapy.
How do they actually relax the muscles? Is it direct action?
Usually not. The vast majority, like the common ones, cyclobenzaprine, Flexeril, are centrally acting.
Meaning they work in the brain, not the muscle itself.
Exactly. Their muscle relaxant effect is largely due to their sedative properties within the CNS. They depress activity in the brainstem, thalamus, basal ganglia. It's sedation that leads to muscle relaxation.
So they're basically sedatives that we use for muscle issues. Is there any that acts directly on the muscle?
Yes, just one main one. Dantrolene. Dantrolene is the direct acting agent. It works right inside the muscle cell, decreasing the release of calcium from storage sacs. Less calcium means less muscle contraction.
And dantrolene has a very specific critical use, doesn't it?
It does. Dantrolene is the specific treatment for malignant hyperthermia, a rare but life-threatening reaction to certain anesthetic drugs.
Since most are centrally acting sedatives, I assume their side effects are similar.
Pretty much extensions of CNS depression, dizziness, lightheadedness, euphoria sometimes, drowsiness, muscle weakness. Overdose is also about CNS depression, supportive care, airway management. No specific antidote for most.
And is there an abuse potential here too?
Yes, particularly with some like carisoprodol, soma. It's sometimes abused, occasionally mixed in a dangerous street cocktail called the Holy Trinity. Usually carisoprodol, an opioid, and a benzodiazepine to get a heroin-like effect. Wow. Definitely something to be aware of.
Okay, definitely high alert across the board.
Yeah.
Let's bring this all together now with the nursing process. How do we apply this safely in practice?
First rule. Always try non-pharmacologic methods first. Good sleep hygiene is paramount.
Like what specifically?
Establishing a regular sleep schedule, avoiding caffeine, especially within, say, 6 hours of bedtime, creating a relaxing bedtime routine, making sure the sleep environment is dark, quiet, cool. These things can make a huge difference.
But when drugs are needed, what's key in the assessment phase?
You need a thorough baseline. Neurologic status, absolutely. Vital signs, including orthostatic blood pressures, checking BP, lying down, and then standing up because of the dizziness risk.
History is important too.
Crucial. Any history of substance abuse is a major red flag with many of these drugs. And you absolutely need to check renal and hepatic function. Get those baseline labs.
Like BUN and creatinine for kidneys.
Yep, and liver function tests like ALP, AST, ALT, especially in older adults, because if their kidneys or liver aren't clearing the drug properly, it builds up, leading to toxicity much faster.
And you mentioned a cultural consideration earlier.
Right. There's evidence suggesting some patients of Asian American backgrounds, specifically some Chinese patients, might metabolize benzodiazepines differently and may require lower doses to avoid excessive sedation or toxicity. It's an important consideration for individualized care.
Okay, assessment done. Now, implementation. Getting the timing right seems critical.
It is. Sedative hypnotics need to be given based on their onset. If it takes 30-60 minutes to work, give it about an hour before desired bedtime. And generally avoid giving them too late, like after midnight if possible, to minimize that next day hangover effect.
How about taking them? With food?
But
without...
For faster onset, taking oral doses on an empty stomach is usually recommended. However, if they cause GI upset, taking them with a small snack might be necessary.
Any special precautions for IV administration, like 5-diazepam?
Oh, yes. 5-diazepam needs to be given slowly. The recommendation is at least 1 minute for every 5 milligrams, and injected into a larger vein close to the IV insertion site to minimize irritation. Avoid small hand or wrist veins if possible.
Got it. Slow push for 5-diazepam. What about patient education? What are the must-tell points?
Safety first. Advise them to avoid driving or other tasks requiring mental alertness until they know how the drug affects them. Warn against abrupt discontinuation, especially with benzos and barbiturates, because of withdrawal and rebound insomnia risk.
And that hangover effect.
Definitely discuss the potential for residual drowsiness, the hangover effect, particularly with the intermediate and long-acting hypnotics. They might feel groggy or impaired the next morning.
This has been incredibly helpful. We've covered a lot, the 4 main classes targeting sleep or anxiety. Benzos, non-benzos, barbiturates, and the orexin antagonists, plus muscle relaxants. Different mechanisms, different risks.
But the common thread for almost all of them is CNS depression, which means careful, individualized nursing assessment and prioritizing non-drug approaches first is always the way to go.
Okay, so to wrap up, here's the final thought we want to leave you with. We use these drugs often to improve sleep. But considering the risks we've discussed, dependence, tolerance, REM interference, the razor-thin safety margin of barbiturates.
How do we, as clinicians, ensure we're actually promoting long-term health and functional rest? How do we avoid simply trading insomnia for a potentially more dangerous cycle of drug effects and dependence? Think about PS, sleeping but still tired. What does that tell us about the quality versus just the quantity of sleep induced by these drugs?
It really highlights the value of those non-pharmacologic strategies and using these powerful tools as judiciously as possible.
Exactly. It challenges us to think beyond just sedation.
Great point to consider. Thank you so much for walking us through this complex but vital area. We hope this deep dive helps all of you listening feel more confident and safe when dealing with CNS depressants and muscle relaxants.